Now he's going to tell us about biomarkers in the subcortical small vessel disease. So this is part of the Gothenburg MCI study. Anders, I'm looking forward to see you very soon in the ADPD meeting in Gothenburg, but for now only by online. So please, Anders.
Thank you, Amos. You could hear me. Is it okay? Yes, okay. Thank you for the introduction, and thank you, Magda, for inviting me to talk here. And I will also be at the ADPD meeting in next month, so we see each other there. And before I start, I would like to, tell everyone that I have this completely the same idea about AD as Amos earlier presented. It is a syndrome, and we of course, we have learned a lot about certain pathogenetic pathways, but we have to, widen our perspective and use other approaches as well. The foundation of AD at present is shaky, as we know, although there are some progress. So I would like to talk now about small vessel disease. That is a completely different perspective on cognitive disorders. And I first something about the conceptual framework, and then how common is vascular cognitive impairment. I will say something about the clinical features of subcortical small vessel type of dementia, and also shortly present what is Gothenburg MCI study about. And then we have previous and new data on biochemical changes in subcortical small vessel disease. And then I would like to conclude, and I have some questions, of course, to all of you too. So first, the conceptual framework. This has been presented in several contexts. 100 years ago, vascular cognitive disorders were very common, and you subdivide, classify them into various categories as well. And then 50 years ago, the scene changed, and vascular cognitive impairment had a hidden position. It was, the general opinion was that multi-infarct dementia was the only way of getting vascular cognitive impairment. And then, as you know, during the last decades, there has been an increased interest in vascular cognitive impairment. First, you formulate a new criteria for vascular cognitive impairment, the post-stroke criteria by Roman et al. 1993, and then subcortical ischemic vascular dementia is another concept. And then you have also included the preliminary stages, very mild cognitive impairment in the vascular cognitive impairment concept. And then also now you discuss also vascular contributions to cognitive impairment and dementia, and that is VCID. So there is an increased interest in this field now, and the terminology is perhaps difficult because you use different terms for almost the same thing. These terms could be used, or often used as a you refer to the same thing, vascular cognitive impairment, although that is more syndromal description. Vascular contributions to cognitive impairment and dementia, that is more etiologically oriented. And then you talk about disorders. You usually do not talk about disease here, because the disease status is still not so well founded. And you also in the DSM-5 discuss vascular neurocognitive disorders, but this is it means that it is a broad definition of this concept. You have cognitive impairment, and it could be mild or advanced, all types of, you have to have signs of cerebrovascular disease according to clinical manifestations and or brain imaging. and various types of pathologies could be involved: stroke, small vessel disease, mixed forms, also Alzheimer's disease is included here, and all types of vascular mechanism could be considered in this broad definition of vascular cognitive impairment. But from clinical point of view and from research point of view, perhaps it's better to be more specific when you do studies and when you manage patients in the clinical setting. And I think this study is quite interesting. Researchers and clinicians were asked, how would you classify vascular cognitive disorders? And everyone said that the mild forms, you do not know so much about them, but the major forms corresponding to dementia are, according to this investigation, post-stroke dementia, multi-infarct dementia, subcortical ischemic vascular dementia, and mixed-type dementia. And post-stroke dementia, then you have to have stroke cognitive impairment in association with the stroke episode. And the other entities, there are no clear connection with the stroke episodes. And this subcortical ischemic vascular dementia, which I will talk about today, could be combined with other entities as well. For instance, Alzheimer's disease and Lewy body dementia and other disorders. So I believe myself that this is a very convenient and very practical way of being more specific when you study and work with patients with vascular cognitive impairment. Then, before I come to biomarkers, I would like to say something about how common vascular cognitive impairment is. And well, you usually in the reviews I've recently read mentioned that the prevalence is about 50 to 30%, 50-20% in Europe and US, higher levels in Asia, and the incidence is 1 to 6% over 70 years of age. But these are epidemiological studies, and you have not always taken into account brain imaging findings. Not all studies have had brain imaging findings, so you could underestimate the rate probably. And also we know from other studies that also the brain imaging findings underestimate the small vascular lesions that you could observe using neuropathological data. This is a really interesting picture, according to my opinion. Here you have done, here you have epidemiological clinical material with autopsy confirmation, and it's a summary of several studies. And here you could see that the Alzheimer, this is the usual way of thinking about the frequency of AD. It increases with age. And here, if you do pathological examination, you see it increases with age, but then it diminishes, whereas the vascular involvement increases deeply. So this is, I think, interesting. It doesn't reflect how you approach this problem in research today. Another interesting summary of various neuropathological studies tell us that the AD-type pathology, where the AD-type pathology predominates, is about 1/4 of the investigated groups, and the vascular type pathway 1/4, and the mixed type 1/4. These studies tell us that the vascular involvement is really important in cognitive impairment and dementia. Now I turn over to the subcortical small vessel type of dementia. And here you have also various types of terminology that could be used for the same thing: subcortical ischemic vascular dementia, for instance, subcortical vascular dementia, subcortical small vessel disease, and also Binswanger's disease, which was described 100 years ago. And subcortical white matter dementia is another almost synonymous term. So this subtype is a fairly common subtype, perhaps not as a pure entity, then it's not as common as some of us believe. Some believe that it's 50% of cases with vascular dementia, but it has not been carefully investigated. Speed, attention, executive impairment are the predominant manifestations in early phases of the disease. It may appear with and without AD pathology, and arteriolosclerosis is present, and you also tissue lesions with white matter verification, microinfarcts, and lacunar infarcts. And this is the typical picture. Here we you have a mild white matter disease here, and more moderate confluent lesions, and here is more confluent lesions in the severe white matter affection. But and important in this context is the vasculature of the brain. Here you have the large vessels that and the penetrating arteries to the white matter and the penetrating arteries to the basal ganglia. And this is an area very sensitive for low perfusion of blood. And here also you have vessel wall lesions of the arteriolosclerotic type. And this is, and here another, the main regions for symptom generation in subcortical small vessel disease is the frontal part. For some reason, they are more sensitive for symptom for small vessel disease of this type than the rear of the brain. And Johanna Wardlove and other colleagues have gone through the imaging findings in detail. And there are not only white matter lesions, there are also small subcortical infarcts, lacunes, dilated perivascular spaces, and also microbleeds could appear in this subcortical small vessel disease entity. And there are attempts also to develop index for the burden of small vessel disease. So I think there are ways of quantifying small vessel disease already today, but more research needs to be done in this area. That was about the entity. And now, what is Gothenburg MCI study? It is a clinical study. It started in 1999, and in the memory clinic at Sahlgrenska University Hospital. And the general idea is to find out more about subcortical small vessel disease, mixed type dementia in this AD plus subcortical small vessel disease. And we do MRIs and biochemical markers. And we also include, of course, patients with mild dementia. We also develop tests for cognition. And it has been presented some years ago, the outline study. And here you have all the schedules of assessment. You have careful investigations, clinical careful investigations with simple cognitive measurements, also detailed neuropsychological examinations. We use 25 different tests And here in the beginning, we had SPECT and EEG and MRI, and also blood sampling and lumbar punctures. The most interesting, I think, the variables in this study are our biochemical and neuropsychological data. And as you can see here, we have every patient is followed up after 2, 4, 6, and 10 years. And there are a lot of investigations. Every patient, if I'm afraid not all patients fulfill this study, because then you have to visit us 25 times. But we have quite many patients at baseline. We also have healthy controls, and after 2 years, and then there is a drop of patients, which of course is problematic, but we try to find out more about the patients in other way. So, and the diagnostic procedure, how do we diagnose this AD mixed type dementia and subcortical small vessel disease? We use the global iteration scale, and that is operationalized used with cognitive status measurement. This is iFlex, is a measure of executive function, MMSE, and CDR rating. And we have some, and based on these instruments, we classify patients as fronto-subcortical, parietal, or that traditional way of doing it. It's very crude, but it's one entrance into the field. And we also use white matter changes on MRI. We use the Fasika scale, mild, moderate, and severe changes. This is another classification system that we do not use for diagnostic purposes on established dementia. We could find out something about the vascular burden as well for other purposes. And this is how our typical subcortical small vessel disease patients is defined. You have prominent speed attention deficits and executive dysfunction, and such white matter changes. That is the typical patients, and a typical AD patient is this one with more parietal temporal symptomathology and only minor signs of vascular involvement. Now to the specific topic of this talk, biochemical changes in subcortical small vessel disease. We have done several CSF studies, and then we have found that the AD group always display A beta 1 to 42, low levels of A beta 1 to 42 in CSF, and increased levels of T-tau and P-tau, as is expected. And then here we have we had just a small amount of small numbers of patients with subcortical vascular disease in the beginning. Then we combined those two into one group, and then we have found that this group also have decreased levels of A beta 1 to 42, but not as high, not as low as in the Alzheimer group. But there were other findings that was not present in the Alzheimer group: increased albumin ratio, increased levels of neurofilament, increased levels of myelin basic protein, and also increased levels of tissue inhibitor metalloproteinase 1 and matrix metalloproteinase 9, that is matrix peptides. So we think it's very important to do more studies and more clearly separate between those two groups, and we have done that in the new studies here. APB metabolites have not been extensively studied today, have been extensively studied in AD, but not in subcortical small vessel disease. And there are soluble APP beta, soluble APP beta alpha and beta, and also various isoforms. Here is one study. We had 30 patients with subcortical small vessel disease, 60 with AD, and 35 with the mixed type, 45 patient controls, and they were, you can see the age distribution. Our mixed type patients were older than the other ones, and we had the controls were younger, but you could compensate for these things using statistical methods. And you can see MMSE scores around 24, 25, and the controls 29. And what we did we find then? We found that there was an increased albumin ratio in the subcortical vascular disease group and decreased APP beta levels compared with healthy controls and with the other groups. That tells us that it gives support for this subcortical small vessel disease entity as a special entity. Then we have a new data. This is in manuscript, and here we have combined A beta isoforms with neurofilament, and 38 patients with subcortical small vessel disease and 121 with AD, and 62 with mixed dementia, 98 controls, and almost the same age as before, as you could see, and MMS score 26, and the controls had normal values now. And when we compared, you did ROC analysis, we compared subcortical small vessel disease with healthy controls. We found that the area under the curve for SAPP beta was 0.73, for NFL 0.84, and when we combined it, there was an improved separation. Area under the curve was 0.90. When we compared SSVD with AD, well, the same separation ability as before, using APP beta 0.75. The AD biomarkers, they are better, they're 0.86. But when we added AD biomarker deviations and SAPP beta, the separation was not better than for AD biomarkers. And the same pattern characterizes the comparison between subcortical small vessel disease and mixed type dementia. So we believe that this combination could be used to diagnose, potentially diagnose. You have to do more study, of course, to this subcortical small vessel disease category in a clinical setting. We have also done other types of biomarkers, more traditional biomarkers in this subcortical small vessel disease, and this is an unpublished study too. Here we have 15 subcortical small vessel disease patients, and 39 AD and 26 mixed type dementia, and 250 stable MCI, SCI or MCI patients. And here we compared the preliminary stages of these entities. We compared preliminary SSVD, AD, and mixed type dementia with stable SCI. And here we found, surprisingly, that the HDL was lower than in the other groups, and low SSVD, low HDL predicted subcortical small vessel disease dementia. And also the triglyceride HDL ratio did the same thing. And also when we did survival curves, Kaplan-Meier investigations, here are the higher HDL tertile and the lower tertile. If it were higher, the risk to develop SSVD diminished, and also the same pattern was seen for the ratio between triglyceride and HDL. So to summarize, this incipient subcortical small vessel disease dementia is characterized by decreased levels of HDL and increased TG-HDL ratio. And here is a published study, almost on the same team, but with a different result in patients with manifest subcortical small vessel disease. The LDL cholesterol level was decreased, as well as triglycerides. So then we have done one study on mixed type dementia, and here it's summarized here. Mixed type dementia has an AD-like biomarker profile, but the phenotype is more close to that of subcortical small vessel disease. So to conclude, the biomarker findings speak in favor of the notion that SSVD is a specific entity. The cholesterol metabolism in SSVD differs from that of AD and mixed type dementia. Is this a clue to pathogenesis? And mixed AD SSVD has biomarker similarities with AD, but few studies have been performed. So what I would like to ask you, is biomarker research in subcortical small vessel disease a relevant approach, and how to act to increase the knowledge about mixed type dementia? Thank you.
Thank you very much, Anders. This was very clear, and we congratulate you on your work. I think I don't know if there are any questions from the floor or from somebody else on the online. I think that this is a complicated issue. The question is really why do you want to have a biomarker for this? If you can, the biomarkers should be used for what? Not for diagnosis, because for diagnosis, it's really enough to have the MRI, and this will settle the point. The other issue, if you want to ask yourself what is the mechanism, underlying mechanism, then maybe you can find a biomarker that will show you or will lead you some way. Why do we need a biomarker, Anders?
Yeah, I think that question is often asked. I think that on using MRI, I mean, the MRI is relevant, but relevant is a static picture. It's just a structure. You can't find out anything about. I mean, you can of course with more detailed spectroscopic measurement, of course, but at least the structural way of measuring small vessel disease should be. You should add factors that are interesting from pathogenetic point of view, at least. So you said it yourself. You think you could get more knowledge about the pathogenesis if you use chemical data. So, but I think here, I mean, the APP findings are also tell us that the A beta 1 to 42 tell us that A beta 1 to 42 is not specific for AD, at least not for clinical AD. On the other hand, people could say that we have not done neuropathological examination, so we don't know. But I think A beta 1 to 42 tells us something about what happens in the brain, but not necessarily that it is AD.
Yeah. So do you think that these biomarkers can be used to follow up patients and to see whether an intervention is useful before you see the clinical manifestation just by looking at the biomarkers?
Yeah, we have that is another. We have some preliminary data I didn't show now on APP alpha and beta. There is happens something before you get manifest, but then it was AD. So, but there are so. I mean, what I would like to do to ask you and inspire you to do more studies in this group of patients. I mean, to define more carefully clinical your material, and then you could get more interesting information. So that is still, we do not have any good progression marker. That is that is a problem. But I think we have also done in other studies measurement in preliminary stages, and then we have found deviations already at that stage. Yeah.
Thank you very much. Chris, are you with us?
Yes, I am. Thank you very much, Anders, for that wonderful talk on MCI. I don't have any questions. I think it's very extensive.
Okay,
right.
thanks.
So I think, Anders, we thank you very much from Thessaloniki and from Brisbane, and we hope we shall see each other, as you say, next month. I'm sorry that you don't join us for Coney this year, but maybe next year in London.
Oh yes, we could have a debate
both
then.
You and Chris, and we can have the interesting debates.
Yes, we could discuss. I mean, we have also we have started a new journal, like I say, that cerebral circulation, cognition, and behavior on behalf of the vascular community, and there I have the privilege to be editor-in-chief for that journal, and that is it's. We have a colleague who is in London too, so it's nice to come in London to discuss various such things, Amos. Yeah.
Okay, that reminds me that we had the vascular dementia congresses that I organized and you participated in many years ago. So thank you very much.
Okay.
Goodbye and see you soon. Chris, thank you very much for co-chairing.
Thank you.